From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to a special edition of JAMA Clinical Reviews. I'm Dr. Kirsten Bibbins-Domingo, the editor-in-chief of JAMA and the JAMA Network. Today, we're discussing the recent publication of the WHO Guidelines on the use of GLP-1 therapies. These are living guidelines, and they're available on the WHO website. JAMA published a special communications from the WHO that summarizes the guidelines as they were currently issued. I'm joined today by Dr. Francesca Celletti. She's the Senior Advisor on Obesity in the Department of Nutrition and Food Safety at the World Health Organization. She is the lead author on the special communications published in JAMA. And I'm also joined by Dr. Ezekiel Emanuel. He's the Vice Provost of Global Initiatives and Professor in the Perelman School of Medicine at the University of Pennsylvania. And he was part of the group that evaluated the evidence that informs these guidelines. Welcome to my guests. I hope we'll be on first-name basis for this interview, Francesca and Zeke. Thank you for joining me.
Thank you. Great to be here.
Thank you so much for having me and WHO. And I just wanted to also recognize how important has been the collaboration with JAMA in this effort.
Fantastic. So these are important guidelines the World Health Organization has issued on an important topic related to obesity and therapies that we are all now quite familiar with. I hope, Francesca, you might start off by just briefly stating what are the two main recommendations that come out of these guidelines?
Thank you so much. And in fact, the guidelines include two good practice statements and two recommendations. First of all, I like to say that the good practice statement, the guidelines are grounded in the recognition that obesity is a chronic disease and as such require chronic care, which needs to be lifelong. And so it is in that context of chronic care for obesity that WHO recommends conditionally the use of GLP-1 therapies in adults living with obesity, defined with the BMI, the body mass index greater than 30. And also, WHO recommends GLP-1 therapy to be associated with intensive behavioral therapy that entails diet and structural intervention around physical activity. So this is the content of the guidelines, which are, of course, also completed by a series of implementation consideration and also broader guidance for member states and the general audience of the WHO guidelines.
Fantastic. That's a great summary. I'd just be curious from your perspective. Of course, clinical guidelines have mostly all incorporated the use of these therapies. They're highly effective and they are a part of the mainstay for many of the clinical organizations around the world. What is the significance of the WHO weighing in with a set of recommendations here? What does the WHO hope to accomplish?
Well, WHO developed this guideline at the request first and foremost of member states, requiring clarity from WHO in how to possibly translate this new science into public health intervention. WHO also responded to the people living with obesity, with the communities affected with obesity and the civil society at large, and also to society. It is true that this medicine has been approved since 2021 for obesity. Nevertheless, it's always very hard, first of all, to translate science into a clear clinical indication, and even harder to translate that clinical indication into a public health policy. So it's really the role of WHO to accompany member states and other stakeholders in how to go through these different steps and really provide clear guidance that goes beyond the clinical intervention and is really aimed to bring that clinical intervention to an impacted population level.
Thank you. So Zeke, you had the hard task with your group for looking at the evidence. And what's come out are very clear statements, but they're also conditional statements. And I hope you would speak to just the general sense of when you looked at the evidence and how we ended up here with conditional statements.
Yeah, I think that's really important. And it actually was something that I had to be educated on in serving on the advisory board for the guideline development. There are probably three important reasons they're conditional statements. The first, and maybe most important, is that the length of study of the GLP-1 agonists and associated other medications is limited to between 6 and 24 months at the best. And that's most of them take patients out a year and then sort of stop. But, as we all know, obesity is a chronic lifelong disease, and stopping after 1 year doesn't allow us to understand a lot of facets of their use in the clinical setting. And so it's partially conditional on that. The second thing that it's conditional on is on the fact that most of the studies, almost all of the studies that are relevant, especially the randomized controlled trials, are done by the drug companies themselves. And so the independent evaluations are a bit limited. And the third thing is a lot of the data and evidence that is evolving is related to things besides reducing weight, right? We were very interested in the impact on cardiovascular disease, renal disease, potentially cancers, and then all the other things we're beginning to learn about the GLP-1s, like addictions, craving for alcohol and cigarettes. So all of those are less well established from an empirical standpoint. So the first thing is this sort of long-term utilization of these drugs. We just don't know enough past the 2-year mark, the conflict of interest of the research, and then the whole other additional effects on health that go well beyond reducing weight, which are super important, and also super important in terms of the cost effectiveness of these drugs, because reducing cardiovascular disease, reducing the need for joint replacement, that dramatically affects the cost effectiveness. And we had an expert from the University of Chicago on the committee who has done detailed analyses of the cost effectiveness, and that was very important.
Super interesting. You've touched on several of the themes that I hope we'll discuss just a little bit more. So the conditional statements allows one to make the clear statements, as Francesca outlined, but recognizes that there's the need for more evidence, higher quality and more quantity of evidence. And that is, in fact, I assume, why the good practice here of having living guidelines that continue to evolve as the evidence continues to emerge.
Yes, I would say that that's another thing, is we have committed ourselves to reconvening on a regular basis so that we can look at evolving evidence. And I think that Francesca will correct me, but I think that there are at least 2 and maybe 3 RCTs that are due to report in the coming year where the data could influence our decisions and potentially change and enhance what we say. So I think we were very cognizant of that impact, and that's one of the reasons that we make it living. And what living really means is we'll regularly review and reassess the data supporting the statements and modify them as appropriate.
Let's go a little bit deeper. So the WHO hosted a webinar to talk about, answer questions about some of the issues related to these guidelines. We didn't have time to get to many of these questions, but some of the themes that emerged when I looked at the questions that were sent in by people who listened to that webinar really many of them related to the long-term use of these medications. So at least there is a body of evidence that suggests that simple discontinuation of these therapies is associated with reaccumulation of weight. That suggests it is likely to be a lifelong use of these medications in some way is going to be part of what patients, clinicians, and all of us who are trying to think about making these medications available will have to grapple with. As you suggest, Zeke, and you talked about, there is both the effects of the medications, there's the side effects, and then there's the also potential benefits of these medications, all of which might play into why one would want to continue them, why someone might want to not continue them. And I don't know, either you or Francesca, talk about, from your perspective, just where do you see either the biggest tensions here, where you'd love to see more evidence, or, these are the questions that people are all grappling with.
Thank you, Kristen. And indeed, first of all, the Guideline Development Group play a crucial role in supporting WHO in understanding the limitation of the evidence, and also in understanding somehow where the research should go in order to answer those questions. The big question here, as Zeke pointed out rightly, is the difference between the long-term use and the lifelong use. There's an enormous difference in the two terms. For the time being, the current recommendation recommend long-term use of GLP-1 therapy using the regulatory definition of long-term, which is longer than 6 months. Nevertheless, there is a lack of data currently on the possible discontinuation of the therapy, maintenance dose, titration of dosing, all that, of course, long-term duration of the study. The study had been limited in time because of the entry into the market of this medicine. But this is a big question. It's a big question not only for the individual care, it's a big question for the health system capacity to address the switch from long-term care to lifelong care, to lifelong treatment. Is a big question also for the government for the allocation of resources, etc., etc. So definitely this is something that we would like to address in 2026 as data come up. We are currently, as Deke was saying, looking forward to results of some RCT that are specifically looking to that question. So this is really a critical question and something that play also the conditionality of the current recommendation. So Ziki, over to you if you want to add anything.
Yes. So I would say, the things that we need to look at very carefully are discontinuation. Why are people stopping? We know that there is a fair frequency of nausea, less of vomiting, diarrhea. There are rare serious side effects like pancreatitis. Another one that actually I think physicians need to be very concerned about is muscle loss. Between 25 and 40% of the weight loss is muscle loss. And we know especially, all of us are familiar with sarcopenia of aging. And, once people get to 60, they begin to lose 8-10% of muscle mass per decade. And if you add on to that, now they're going to lose more muscle mass. You got to worry about frailty and things like that. So some of the big questions for us is, how frequently are discontinuation because of the side effects, and can that be reduced? If people lose, say, 20% of their weight in the first year, which seems to be 15 to 20% seems to be about the number that people lose, can we titrate the dosage down so that we can, I guess the phrase on the street is microdose this stuff to maintain the weight, but not have some of these other side effects like muscle loss? So I think those are very big questions. And could you maintain it for a long time? There was a recent report actually about, at least initially, no impact on obesity-related cancers. That's going to have to be looked at because I think that's an important factor. So I think there are a lot of unanswered questions. I would say that from my reading of the data, and I think the entire guideline developing committee, mostly we were looking at positive data, the impact on cardiovascular disease, 20% decline in MACE in 1 year is like pretty amazing impact. The impact on renal function, the impact on osteoarthritis, and therefore hip and knee replacements. So all very, very important. And as I think Francesca said, the most important thing is how do we get the people to the lowest possible dose with the fewest side effects that allows them to maintain the weight loss and the additive benefits from weight loss? We don't know the answer to that question. And that's probably, I would think, the number one issue that we have to find out going forward.
Yes, I think both those statements are really well taken. You're speaking to both when there are therapies like this that have really are highly effective and have captured the imagination of so many people because obesity is such an important issue that, the practice is moving ahead of where the evidence is. So microdosing is a good example of it sort of makes sense intuitively, and there's a need because people do have side effects and people are likely to be on these longer term, but we're clearly ahead of where any good evidence is, solid evidence on how one would do that. And the other thing I think of as I'm a general internist, and that I think we see in the clinic is the issues of the reduction in muscle mass that comes with this also factors into an area where we need more evidence, but also factors into how do I think about this across the life course of patients that I might see in practice. So there's a difference for when I have a 25-year-old who I can take many more proactive steps to forego the muscle mass loss that might come with the use of these, to trying to make a more complex decision in an older person who might benefit from many of these additional benefits from these therapies, but I might also be thinking about issues of frailty and other types of, and how those factor in. And I would say clinically, those are the discussions I'm having with my colleagues in clinics, having with patients. And I don't think we have quite enough evidence to help tell us exactly what the right answer is there.
Well, I think that's an incredibly important point. One of the things that we were frustrated by on the guideline committee, and therefore the conditionality on the recommendation is low, is that the use of these medications be combined with dietary interventions, behavioral health interventions, exercise. We don't know whether that combination is more beneficial, allows people to maintain the muscle mass. Those are going to be really important questions. So that was low quality evidence, because those kind of studies where you put the medication and these other lifestyle changes into effect is a really important question. So if you have a 25-year-old and you put them on the medication and they're at risk for muscle loss, if you put them in an exercise regimen that is strength training, will that, preempt the muscle loss? Really, really important question. And the same thing for a 65-year-old who's facing, the next decade going to lose 8 or 10% of the muscle mass. I think we just don't know. And we really need to know to be able to, as you point out, effectively manage patients on these medications.
Yeah.
So that's the challenge, both for the science, but also for the clinical practice. And this is where we have to marry up so that the science can actually inform the clinical practice.
Yeah. Francesca, let me ask you about this. So, the World Health Organization, very important organization, an important voice in public health. I think the issues of healthy diet, of physical activity as the basis for a healthy lifestyle in general, many in the public health community write about, as the WHO have written about, the environments that enable these types of healthy lifestyle choices that facilitate healthy diet and physical activity. Was there tension at the WHO coming in with a strong recommendation about medicines as the main way to go here, when there so much discussion, I would say, in general, also needs to focus on how do we have environments that are facilitators of healthy diet and physical activity that are important just for health in general, but also likely to be a component for how we address obesity?
That's a very relevant question. And WHO emphasizes, in fact, Kirsten, that while we do recognize that if used appropriately and in the right condition, GLP-1 therapy might be transformational. And maybe we'll get to that in what is the WHO thinking behind the power somehow that this therapy can have in shifting the epidemiological trajectory of obesity and other NCD. But medication alone will not solve the problem. Already within this guideline that are very focused and narrow on GLP-1 therapies and chronic care for people living with obesity, we do recognize the role of associated intervention like structured dietary and physical activity. Not only has something to improve certain aspects of the, like, for example, loss of muscle mass, but really because the data are showing that they amplify the impact of the GLP-1 therapy themselves. So just also as for that condition, in addition to a series of other things. However, obesity is so complex that needs a multi-phased response, and the health system is just a component of that. And when I say health system, is already beyond GLP-1 therapy alone, is already about chronic care. I think the GLP-1 therapy and the reshaping of the new narrative about obesity being a treatable and preventable disease need to trigger and reinforce the need for re-engineering and rebooting an ecosystem around the individual, around the health system that touches upon the food environment, the urban environment, the workplaces, where in concert, different stakeholders need to work together to really, on one side, address the root causes of obesity that we know there are socioeconomic factors, there are environment factors, and then go to the possibility of treating this disease and possibly reducing the burden on health systems. So it's really a complex solution that has to be put in place. And with reshaping the narrative, GLP-1 therapy might have the role to declick something that evidently, from at least the prevalence data, we haven't been doing so well in the last decades, because we have had a massive increase of the obesity prevalence. And today we have 1 billion people living with obesity. This is a scale of a problem that we never had before. 1 billion people with the disease.
So what I'm hearing from you is sort of the urgency and the reality of these highly effective therapies and the urgency of the problem that I think compels at least the look and the incorporation of these therapies into the solutions related to the prevention and treatment of obesity. But it shouldn't be that these are replacing what we also have to tackle in the environment to create a more healthful environment for people. Ezekiel, I thought you wanted to come in and say something.
Yeah, I want to echo and maybe put a slightly different accent on what you just said. Look, we didn't get to 1 billion people in the world, 15 to 20% of the world population obese, because the genes in the human gene pool changed, right? We got here because obesity is a social disease, which means that we've created a social environment where it's easier to become obese than it is to stay healthy. We know, certainly in the United States, ultra-processed foods are cheap. They're also addictive, both in the technical sense and in just, the colloquial behavioral sense that, that famous ad for a potato chip, you can't just eat one. That's right. They formulated it so you can't just eat one. And we need to change all of that. In the United States, our big problem is subsidies for the components that make ultra-processed foods and therefore make them cheap because we subsidize the farmers. We need to shift that. We also need to get, I recently become a big advocate of reintroducing home economics into school so kids learn how to cook. So many of my students who are younger and my research assistants don't know how to cook. And, if you can't cook, it's hard to eat healthy. It just really is. And so I think we need to think more expansively if we want to get our arms around. GLP-1s are one component of that, but from a social component, we can't have people eating, getting fat, and then going on drugs. It's just not going to work socially, economically, and it's not going to be good for people. I will say one thing I have noticed, and purely anecdotally here, so no data, the people I know who've gotten on GLP-1s, and I have a very dear friend from college who I recommended getting on, and he said almost immediately, his relationship to food changed because the drugs were clearly affecting the central nervous system, and his relationship to how he perceived food, his craving for food changed. And I think one potential real positive of these drugs is that they give people hope, that they change their relationship to food, they see they can lose weight, and that they begin to invest in all the other good, healthy wellness activities that are important: eating better, exercising, sleeping. And that would be a major, major cultural shift for these people, and I think really kind of important. But we as a society can't sort of say, well, it's all on the individual, because society has a big responsibility to make positive changes, to make it easier for people to eat healthy, to exercise, and do all the things we as physicians recommend and know are highly correlated with living a long and healthy life.
Yes. Thank you so much. Those are really excellent statements. Let me turn just to another theme that came up, and I think not surprisingly is the equitable access to these highly effective therapies. So in the US, these are very expensive therapies. They're expensive, I think, around the world, although I'm sure the prices vary. And in the US, there have been different models. We've been thinking about that. But certainly when we think about the globe and the variation in the health system's preparedness to incorporate the use of these and to distribute to populations, how do we think about the equitable access issues? Where are the opportunities, and where in particular, what is the role of the WHO in continuing to foster those opportunities to make sure that patients, that individuals, that clinical settings have access to these medications?
This is a very important question, in fact, Kirsten, and definitely the equitable access in the specific of GLP-1 goes beyond the price. Definitely the current price is high and unaffordable for many people around the world across different countries. This is not just a matter of low and middle income countries. This is a universal issue. So there is the need to work as a global health community to really put in place mechanisms that can really lower the price. We have seen in the past, we have had several examples from large-scale health programs that have put together a different strategy according to context, which can go from local production to voluntary licensing to mandatory licensing to pool procurement, et cetera, et cetera. And this is not just one entity that can do this alone. This is really the global community coming together with a different capacity and really bring that price down. WHO has a role to play into this, and we are halfway, I should say, because first of all is the inclusion in the essential medicine list. This was done in September. We have followed with the guidelines, the clinical guidelines that represent one of the pillars of the access ecosystem. And then, of course, the PQ that definitely can support large-scale procurement mechanism. But the price is only one issue. To really have an equitable access, the health system have to be ready to receive this treatment, because the fact that a medicine is affordable and available and registered in the country doesn't mean that reach the people in need and that people can access sustainably and long-term or lifelong, whenever that answer will be answered. And then the third, so there's a big component that government need to put in place to really prepare the health system to offer chronic care, including GLP-1 therapy. And the third component is the universal access to care. Because even if we have affordable pricing, if we have health systems that are ready and are capacitated to provide that and offer this chronic care to people, that care have to be provided free of, it shouldn't be supported by out-of-pocket payments. So it really has to put in place whatever financing mechanism country use in terms of universal health care packages, primary care benefit packages, and national health insurance plan, private health insurance. We do have, again, a set of different mechanisms that can be put in place. And only that, when then is reached, we can talk about equitable access to this life-saving treatment. Because after all, this is a life-saving treatment if you think about the burden of obesity and associated comorbidities. So this is a big commitment, and this is where WHO plays a role. It's a big commitment from the global community, it's a big commitment from the government, and also, if you like, a big commitment from the people living with obesity or comorbidities that had to join and be in this chronic care journey lifelong.
We had a number of patients with obesity who were on the Guideline Developing Committee, including many from lower income countries, low, middle, and low income countries, who are very, very eager to have access to this. That's the first thing. So I think the desire among the obese population to get treated is universal worldwide. And I think Francesca says correctly, access, just having it as a cheap drug doesn't solve the problem. There's a whole infrastructure that has to go through it. The thing that makes me most optimistic are two factors. One is semaglutide is coming off patent in the next couple of years, and that I think will change the ability to produce. It's not a very expensive drug to produce, so that will change some of the financing dynamics. The second element is there are more than 40 other GLP-1 related compounds being developed, and that will hopefully have some economic impact. It also may dramatically affect the different delivery mechanisms so that it's easier to take than an injection. The thing that also worries me most, and this I think we haven't discussed, is the issue of counterfeit drugs. Because the desire is high, we know that counterfeit drugs are one of the biggest scourges of the world. People being sold something which is not the medication cheaply, and being able to control that process so people don't get ripped off, as it were, looking for a solution to their obesity. Super important around the world. And this, again, it's important for the WHO to take a stand, and it has taken a stand on that, but super important for the rest of the world to enforce those conditions so that we can root out all the counterfeit medications.
Thanks. That's a really important point. I'm glad you brought that up as well. I want to congratulate both of you on a successful launch of the guidelines, but also for stimulating the discussion that, when the WHO issues guidelines like this, I think it both speaks to helping guide where we should be going, but also opening up the discussion about where do we need more evidence, where do we need more activity, what are the questions that we all need to be addressing. So I think that's been an exciting part of this process as well. I'm going to let each of you give me a takeaway that you want to leave our listeners with. Let me start with you, Francesca.
Thank you. Thank you. This has been very nice. So the takeaway is just looking into the future, at least for us. We do believe that this medicine, as I said, can, if used appropriately, can be transformative. And we need to be really looking at not only the impact on treating obesity, but on a broad range of metabolic and cardiometabolic diseases. And so we really need to be hopeful and try to shape the system, not only the health system, but the overall system, to really use this opportunity to shift the epidemiological trajectory of NCD burden. This is something that we can do as a global community. WHO is committed to do it, and we need everybody on board, the scientific, academia, civil society, government, to really make sure that this change will happen and we can see that change.
Fantastic. Zeke?
Yeah, I like to say that since the end of the Human Genome Project in roughly 2000, there have been 5 major breakthroughs in biomedicine. There's been CRISPR, there's been gene therapy that have allowed people to be cured of blindness. There's been CAR-T to take people on their deathbed and literally save their lives and give them another chance. There's been the whole mRNA vaccines, but also now increasingly possibilities of cancer vaccines from mRNA. And then I think there's been GLP-1s, which are truly transformative, going to impact billions of people in the world. And the responsibility for the rest of us is to treat our patients in front of us and to get them on the best treatment and to make sure that they're healthy and, to basically care for them with this very, very important chronic disease. And I think we're now recognizing, because of GLP-1s, that obesity is a chronic disease. It's not a sort of lifestyle choice that some people have, or the prejudice against people who are obese. But it also means that the whole of society has a responsibility to try to make having optimal weight and being well possible and easier to do, both in terms of the food supply we have, in terms of the way we exercise, and in terms of our built environment. So I think that's the takeaway. There are clinical things that we can do, but there's also things that we have to have our society do that makes this possible to integrate and be effective.
Fantastic. So, Francesca and Zeke, I've really enjoyed this conversation. I hope you'll come back and we can talk again as we have more evidence about this important issue. I'm Dr. Kirsten Bibbins-Domingo, the editor-in-chief of JAMA and the JAMA Network, and I've been speaking with Dr. Francesca Celletti, the senior advisor on obesity at the World Health Organization, and Dr. Ezekiel Emanuel at the Perelman School of Medicine at the University of Pennsylvania. They are part of the group that has come together to issue the World Health Organization guideline on the use and indications of Glucagon-Like peptide 1 therapies for the treatment of obesity in adults. Special communication published in JAMA to coincide with the launch on December 1st, 2025. I'd urge you to go and read these guidelines and to engage in the more discussion on this topic. You can find a link to the articles in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.